So in our septic shock, do we have to have an hemodynamic protocol to manage these patients, or usual care is enough? The story starts with the famous study of Rivers. It's a study performed in the emergency department. It's in one center. And the idea was to try to manage these patients with an hemodynamic protocol based on the CVP to analyze the volumic status, to be sure that it's possible to get a mean arterial pressure greater than 65, and to try to see if the oxygen delivery was optimal, looking at the SCVO2, and also to be sure that the hematocrit was enough, greater than 30%, and to try to obtain the goal of CVP between 8 and 12 millimeters of mercury, a mean arterial pressure between 65 and 90 millimeters of mercury, an SCVO2 greater than 70%, and an hematocrit greater than 30 grams per deciliter. So in terms of mortality, it was a success because Rivers observed an improvement of mortality applying this protocol, and you can see that it was a huge decrease in mortality, because in the standard therapy there was around 46% of deaths, and when he applied an early gold directed therapy, he observed 30% of deaths. So very impressive result. And after this study, there is several non-randomized control study who support this early goal-directed therapy, and prove that by applying this strategy, it will be possible to decrease the mortality. Until the process study. The process study, it's a randomized control study, and it's a multi-center study where they divide the study patient in 3 groups. The first group, it was similar protocols than in the River study, based on the CVP, mean arterial pressure, SCVO2. And the second group, it was a protocol for standard therapy. So the volumic expansion was based on the shock index, the ratio of heart rate to mean arterial pressure. And what was interesting in this study is that they look at if they had a sign of hypoperfusion, and it was defined by the fact that despite fluid resuscitation or vasopressor, they was not able to get a mean arterial pressure greater than 65, or an increase of lactate, or a melted skin, or oliguria, or altered sensorium. So clearly an evaluation of the fact that potentially there is still an hypoperfusion despite fluid resuscitation or vasopressor. And the third group was the usual care. So physician can do what he wants. And in terms of result, you can see that in the goal-directed therapy group, they receive more vasopressor, they receive more red blood cells, more dobutamine in comparison to the two other group. And in terms of volumic expansion, it was similar between the early goal therapy and the protocol-based standard therapy, and maybe a little more in the protocol-based standard therapy, and less volumic expansion in the usual care. What about mortality? No difference. No difference. So no effect of the early goal-directed therapy. And it's one very important point is to see how the mortality was low in this study in comparison to the study of Rivers. A second study, the ARISE study, it's the design is early goal-directed therapy against usual care, and in terms of mortality, no difference. And once again, a very low mortality in this study. A third one, the PROMISE study, and the same result, so a failure of the early goal-directed therapy to decrease mortality. So do we need a hemodynamic protocol? Not sure. The usual care seems largely enough. And but just to open the discussion, some remarks about this. So it's very surprising to see how low the mortality was in the 3 randomized control trials. It could be a selection bias, or it could be the fact that we progressively, during the year, the mortality of septic shock is decreasing by the fact that we are capable to apply hemodynamic protocol, and we clearly do better and better. And maybe over time, the usual care is changing. And the surviving sepsis campaign has clearly an impact on mortality, and it's why we are not able to see now a difference between an early goal-directed therapy and the usual care, because we are trained to apply the early goal therapy without protocol. So it's a great success of the surviving sepsis campaign, maybe. And just to highlight some point, when you look at the 3 randomized control, recent randomized control study, you can see that what is a little bit surprising is, in addition to the low mortality, is the fact that you have a high exclusion rate and convenient enrollment, and a low patient per seat was included, and this clearly challenged the external validity of these 3 trials. Another point is that if we compare to the River study was mainly performed in the emergency department, and patients were included around after 1 hour, so in a very early phase of the septic patient. And it was not the case in the 3 other trials, where the inclusion was later. And clearly the question is, it's possible that in these 3 trials you have an early optimization before randomize. And this is, if you look at the SCVO2, at the time of inclusion, you can see that the SCVO2 was very high. It was greater than 70% in the 3 trials. So it's when they randomize the patient had an hemodynamic optimization before randomization. So it's completely different than in the River study, where you can see that the lactate was clearly higher than in the 3 other trials. and the CVP was clearly decreased. So clearly in the reverse study, the patient was more severe and less optimization before inclusion. So I think that this has clearly an impact on the result of the three trials. And the usual care. When you see, for example, in the process study, the usual care, the results are clearly the same in terms of practically the same vasopressor, red blood cells, and fluid administration than the protocol-based standard therapy. It's the meaning that the usual care, when a physician apply in this study, the usual care, he take into account the fact that he is concerned about hypoperfusion, and clearly he manage his volumic expansion or catecholamine based on clinical sign of potential occult hypovolemia. So he is doing very well, and I think that usual care clearly is improving in this study. So how we can design hemodynamic protocol? I think we have to think about what clearly are the resuscitation endpoint, and to evaluate the volemia, maybe the CVP is not the good index. We know that there is no gold standard for monitoring adequate fluid resuscitation. We know the limit of the CVP, and we know also the limit of the SCVO2. The SCVO2, when it's low, we know that we have a problem. We have an hypovolemia, we have a problem of cardiac output, we have maybe a problem of inadequate hemoglobin. But when it's high, what is the part of the microvascular dysfunction? What is the part of the fact that tissue are not able to use oxygen? So it's very difficult to deal with the SCVO2. And clearly, we have to find other index to evaluate fluid responsiveness. We have to think about what is the good target for arterial pressure. We have to evaluate our cardiac function. It's so important because in the different protocol, you can see that they introduce dobutamine when everything fails to improve the oxygen transport without evaluation of the cardiac function. I think it's over. We have to evaluate cardiac function using echocardiography. And also tissue perfusion and oxygenation. We have to consider lactate, we have to consider diuresis, and in the future we have to consider to evaluate microcirculation. Just to see that in the recent recommendation of the Surviving Sepsis campaign, you can see that now it's recommended to have a frequent reassessment of hemodynamic status. We have to use dynamic over static variable to evaluate fluid responsiveness. We have to assess cardiac function, and we have to have clearly goal of tissue perfusion, lactate, or maybe in the future other goals. And just it's the protocol that we use in my unit. It's just to we can build plenty of protocol, but just I want to highlight some point. The first thing is when you have a problem, it's a low mean arterial pressure, a low urine output, or an increase of lactate. The first thing to do is to perform an echography just to evaluate your left ventricular function, and just to be sure that you have not a failure of the right ventricular function. And after, we have to combine several index to evaluate the volemia. It could be the CVP, but we show the limit. certainly, the variation of pulse pressure are a very good index in a ventilated patient. Echocardiography could be very useful also. And if you have doubt, you can perform a passive leg raising. What about the target of mean arterial pressure? It's really a very important question. This study where Pierre Asfar in septic patient compare two group of patients depending of target of mean arterial pressure, a high level of mean arterial pressure around 80 and 85 millimeters of mercury against a more classical target of arterial pressure, 65 to 70 millimeters of mercury. And what they observe globally no difference in mortality, but when you look at patients who were hypertensive, there is clearly a difference in mortality. So the target of mean arterial pressure is certainly not the same in patient with an hypertension and without an hypertension. And I think that in the future, we have to consider this. So another point is that when we consider patient after optimization, for example, in this study of Daniel De Becker, when he observed microcirculation using a camera under the tongue to see how microcirculation was in this patient after hemodynamic optimization, you can see that despite the fact that you have an optimization of the macrocirculation, the microcirculation is still altered. And what was very important in this study, if you consider the mortality of patients, you can see that the percentage of microvessel perfused was the better index for predicting mortality, better than lactate, better than SCVO2, and better than mean arterial pressure. It's the sign that despite the fact that we are capable to optimize macrocirculation, we are completely blind considering microcirculation, and we have a lot of work to do in this direction. And just to illustrate this, it's data from my unit where we use echography at the level of kidney, and we use its contrast-enhanced echography. We inject microbubbles, very echogenous microbubbles, and I want to show you it's 3 patients, it's 3 septic patients after macrovascular optimization. We look at the level of the kidney, and here is, if it works, what we observe. So the 3 patients were at the same mean arterial pressure, the same cardiac index, and here the perfusion was, I don't know if was okay at the level of the kidney. But in some patients, we had this, no perfusion, practically no perfusion. And in some, we have this, a very high flow. So independently of the macrocirculation, independently of the optimization of the macrocirculation, independently of the fact that we think that we had done a good job, at the level of the organ, we are completely blind. It could be good, it could be terrible, and it could be high flow. So I think that the story is not over. And just to show you globally the result, if I compare during this, it's a result of the study, and in comparison to control group, in septic patient, we have clearly, despite this high variability, clearly a decrease in the perfusion index at the level of the kidney. And if we compare septic shock, who develop acute kidney injury and septic shock who did not develop acute kidney injury, clearly a patient when we observe an alteration of microvascularization at the level of the kidney, we had an acute kidney injury in this patient. So it's why it's so important to be able to have an idea of the microcirculation at the level of organ to be able maybe to improve our macrovascular resuscitation, trying to improve microcirculation. So clearly in the future, the fact that we will be able to personalize care is really the way that we have to move on. And to conclude, so hemodynamic protocol were a contributing factor to the change in the management of sepsis over time and to improve mortality. We have to think about what are the good resuscitation endpoints, and in the future we have to consider patient and try to have a resuscitation goal personalized for each patient. Thanks a lot.